going to get started here. This is Behavioral Health 201. This is our fourth session. Thanks for joining us this morning. Before we get started with our presentation, I just wanted to remind everyone that if you are seeking MOC, CME, or any continuing education credits, that attendance is required, so you want to make sure you're filling out those after-session surveys. And for some of the providers, the coursework is also required, and that can all be found on Umbrella. If you have any questions, feel free to ask me or your practice consultant about logging in and uploading that. Again, you can email me or your practice consultant. I'm going to toss it to Jonas, who's going to talk to you guys about the ASAP consult line.
So I just wanted to remind everybody about the change in phone number and process for getting a ASAP consult. So that consult line is now being supported by MCPAP and the Department of Mental Health. So you will call your normal regional MCPAP number to request an ASAP consult, and they will connect you with the ASAP consultant. So that's the pathway now. I just want to remind people about that. That's the best way, the quickest way to get that consult. So that information will be in the slides that we share with you after the meeting as well, so you can let everybody else in your team know. All right. And I just want to introduce people you have probably met already in one capacity or another. Mimi Shizer has been our faculty member for our substance use part of this since we began, and has helped evolve and develop this content and part of the program in a number of ways. And today she's going to present on a relatively new topic that's new to the curriculum over the last couple of years. And then we have Bill Riccardelli here today to do a brand new piece of content that's in response to something that we hear y'all are being bombarded with everyday questions about CBD. So he's going to give us a very in-depth talk about that, and we'll be repeating that this spring, March, May, I don't remember the date, but we'll send it out on a webinar Wednesday, so everybody in your offices, would have an opportunity to hear that. It's kind of the #1 question, maybe, competing with marijuana. So, Bill, go ahead.
Okay. Good morning, everyone. I'd just like to send out a brief thanks to Jonas and Jane for helping to arrange this. And I'd also like to thank my colleagues. I'd like to thank Dr. Mimi Shizer for graciously allowing me to use some of her slides. And also Dr. Sharon Levy, who's our director, and who helped me compose this presentation. So, let me just see how we're advancing the slides here. Can I have someone? Oh, there we go. Okay. Okay, so the title of my talk is to CBD or not to CBD? That's the question. And CBD has seemed to have caused almost like a mass hysteria among families, and it seems like people are looking to it as a panacea, a cure-all for any ailment under the sun. I have a pretty firm stance on CBD, especially in adolescents and youth, and I think by the end of the presentation you'll understand my stance, and I hope that this gives you some information to come to your own conclusions. My objectives for the talk today are to describe the difference between medical marijuana and pharmaceutical preparations, list the adverse effects of marijuana on the developing adolescent brain, and identify conditions for which there's strong evidence for CBD as a medication. So I have no financial disclosures or no conflicts of interest with the material that I'm presenting today. Let's start at the beginning. The beginning is always a very good place to start. We're going to talk about some terminology. Cannabinoids. Cannabinoids are molecules. They're chemical compounds, and they're found in the marijuana plant and also in our body. There are different categories of cannabinoids. Endogenous cannabinoids are found in our central nervous system and our peripheral nervous system. You can think of them as neurotransmitters. Exogenous cannabinoids are found in the marijuana plant, and they're also referred to as phytocannabinoids from the Latin for plant. Does anyone recognize what these two cannabinoids are? If anyone does, I will sit down and you can take over this presentation. So the light greenish blue molecule is anandamide. This is what's known as the bliss molecule. You may have heard of it. It's from the Sanskrit for joy or bliss. And the purplish cannabinoid is unfortunately much more well known. That's THC. So you can see how they're structurally very similar, and they bind to similar receptors in our brain. And in a way, the THC is fooling the brain, thinking that it's anandamide. Anandamide is released to reinforce positive behaviors such as exercise, eating, dancing, listening to music, pleasure-inducing activities, also having sex. So these molecules bind to receptors in what's called the endocannabinoid system in our body. There are two main sets of receptors, the CB1 receptor and the CB2 receptor. The CB1 receptor is located primarily in the brain, the lungs, the vascular system, and the gastrointestinal tract, and the liver. The CB2 system is primarily located in the spleen, the immune system, and the bone marrow. The main functions of the endocannabinoid system are to coordinate body movements. It helps with memory, also our perception of pleasure, and the sense of time passing. These are all regulated by the endocannabinoid system. There's also activity in the immune system, and particularly the CB2 receptors are involved with the activation of macrophages, neutrophils, and other bone marrow functions. So you can think of the endocannabinoid system as regulating brain activity. It's like a volume control on a radio. And when the endocannabinoid system is activated, it actually turns down the amount of brain activity. It also helps with regulating pleasure, mood, pain, motivation, and memory. And there's one other domain. It helps with shaping brain development. It directs the mapping of neuronal growth and the proliferation of specific neurons for correct brain functioning. It's also involved in the deposition of myelin tracts. Specifically, what tracts are myelinated and when they're myelinated. Okay, so there are thousands of different types of cannabinoids found in the marijuana plant. This is a graph just displaying some of the more common ones. THC is, of course, the psychoactive ingredient in marijuana, and we're going to come back to that one and speak about it separately. I'm going to start with cannabidiol, which is towards the bottom, CBG. CBG is reported to have bactericidal properties and also to help with the reduction of inflammation. It also has appetite stimulating effects, and it's a precursor to cannabidiol. There is an interrelatedness between these molecules. Some of them are precursors for other molecules, and others are the breakdown products of certain ones. Cannabinol, CBN, is actually found in aged marijuana plants, and it's believed that over time, THC forms CBN. CBN is the most sedating of all of the cannabinoids. CBC is cannabichromene, and cannabichromene has been found to have antidepressant properties. And the bottom one is tetrahydrocannabivirin, THCV. This cannabinoid also has psychoactive properties, but it actually has properties that are very different from THC. THCV acts as a stimulant. It actually increases concentration and it increases energy. So let's look a little bit at the marijuana plant itself. There are different species of the marijuana plant, and within the different species, they have different concentrations of the cannabinoids. This is why people have different effects when they smoke different species of the plant, or when they use in any way, if they eat, if they consume in an edible the plant. Cannabis sativa has a higher concentration of THC than cannabidiol. Cannabis indicus has a higher concentration of CBD than THC. So when people use cannabis sativa, they have more of a mind-altering experience. They feel extremely high. Right? People say things like, I was zooted. With cannabis indicus, they feel much more sleepy, much more sedated. And that's because there's a higher concentration of CBD, which we'll get to. So THC, tetrahydrocannabinol, this is the most common ingredient in the cannabis plant. It is a psychoactive substance in that it produces a euphoric feeling and a mind-altering high. The concentration varies in different species of marijuana plants, which I just mentioned, and the concentration also varies in different parts of the plant. I want to make a point here. When people talk about smoking dabs, they're smoking a very, very highly concentrated form of THC that's extremely potent. It is derived from the plant, but it's been altered. And 2 or 3 puffs of a dab's form of THC could be equal to smoking hours and hours of plant-based marijuana. So it's very important to keep in mind when people are using dabs, it's an extremely, extremely, extremely highly concentrated form of THC that they're getting. THC is fat-bound. It is able to cross the blood-brain barrier and the placenta. There's substantial evidence that shows it is associated with an increase in psychosis. And THC is detected on standard urine drug tests. I want to go back to the fat-bound notion just for a moment. When I see teenagers in the clinic, I ask them, where is the fat in their body? And a lot of them tell me that the fat is in their stomach, even very, very, thin adolescents. and I tell them there might be some fat, in your abdomen, but there's an area of the body where there's much, much more fat. And I ask them to guess, and no one guesses correctly. I'm looking for the answer, the brain, right? The myelin sheaths are lipid molecules. So I tell them, when you smoke marijuana, where does it go in your body? And none of them are ever able to guess correctly. It goes to the fat. And they think it goes to the fat in their belly. It really, really goes to the myelin sheaths. It goes to the fat in the brain. So when people are talking about THC being stored in the body, it's actually being deposited in the myelin sheaths. Over time, the potency of THC in marijuana has increased exponentially. This slide is looking at the potency or the concentration of THC in samples of marijuana plants that were obtained by federal authorities from 1995 up until about 2015 or 2016. There's a program at the University of Mississippi where they record this data. And it clearly shows that the potency has increased over threefold. In 1995, the average THC content of marijuana was about 3 to 4%. It has increased on average to about 13 to 14% based on the results from 2015 to 2016. Keep in mind that people are selectively breeding strains of marijuana where the potency of THC is now up to 30%. So as the THC content in the marijuana plant has increased, so has casualties in many, many different realms. This depicts an increase in the number of emergency department visits that are related to marijuana use per 100,000 people. In 2004, there was about 96 per 100,000 people presenting to ERs with marijuana-related claims. In 2011, the number has risen to almost 150 per 100,000. And there is similar data showing that there's been a directly proportional increase in the number of school suspensions and in the number of marijuana driving related car accidents as the potency has increased. I want to say a few words about synthetic cannabinoids while we're going over the introductory information. Synthetic cannabinoids are extremely dangerous compounds. They're known as Genie, Spice, K2, Ninja, fake weed. And these are actually synthetic chemicals that are sprayed onto dried plant matter, and people can either smoke it, people can eat it, people insert it rectally. Synthetic cannabinoids have absolutely no medical use at all. They're extremely potent, up to 10 times the potency of regular THC. And that's because they work as a full agonist on certain receptors. Like I said, they are extremely dangerous. There have been deaths from people who have used these compounds. They can cause psychosis, renal failure, seizures, delirium. If anyone is working with a patient who they suspect used these compounds, you are required to call poison control and make a report. The Food and Drug Administration in 2018 issued a warning that quantities of broadifacum had been found in synthetic cannabinoids. Does anyone know what broadifacum is, the ingredient? So it's the active ingredient in rat poisoning, and it is a potent anticoagulant. So there's a bleeding warning with these compounds. People that abuse them have been presenting to ERs, bleeding from the gums, and they can have internal bleeding. So that's why poison control is also involved. Okay. Let's now start to get into some of the information that I'm here to talk about. Cannabidiol. Cannabidiol is the second most common cannabinoid in the cannabis plant. This slide says it does not possess psychoactive properties, and I want to explain. It does not induce euphoria. It does not cause mind-altering sensations, though it is sedating. So in the sense that it's working on the central nervous system and it can cause sedation, you may say it has psychoactive properties without the high, but when I'm referring to not having psychoactive properties, I specifically mean it's not euphoria inducing, it doesn't cause a high. It's not addicting. And remember, I had said before that the different species of the marijuana plant present different quantities of the cannabinoids, and cannabidiol is found in higher quantities in the cannabis indicus strain. So people that are smoking cannabis indicus, they're more likely to feel sedated. Now, when people talk about getting CBD, there are several sources they can access CBD from. They can access it from the marijuana plant itself, and they can also access it through artisanal supplements. And there is a limitless array of supplements that contain marijuana derivatives and cannabinoids available. So the FDA has declared that it is completely illegal to promote CBD as a medication, and it has not given the approval for CBD to be marketed as a dietary supplement either. This is largely not enforced. The FDA simply does not have the manpower to police every company that is producing supplements. What the FDA is trying to do is to investigate products where they make specific claims that the CBD targets a medical condition. We all know that the supplement industry is severely underregulated, right? So that holds true even more so for these products. The quantity of CBD is really unable to be substantiated. The variation in the quality of the cannabinoid is variable. And even in one product, the amount and the quality of the CBD can vary from batch to batch. So in a sense, you really don't know what you're getting. I just want to pause on this slide. You can see the dog bone. So there's an emerging market of CBD use for pets. I've been seeing this more in the literature. I heard from some veterinarians that people are coming in with a lot of questions about giving CBD to their pets. The mascara, the claim for the mascara is that it makes one's eyelashes longer and curl more. Yeah. And then, it's also concerning because a lot of them look like candy, right? So there's the danger and the appeal that kids will get into them. So there have been some really, really nicely done studies that examine the labeling accuracy of THC and CBD in these products. This information comes from a JAMA article that was published in 2015, and they examined through laboratory analysis the THC content in a number of products, and they found 17% of them were labeled correctly. Okay, so that's over 80% of these products were inaccurately labeled. Additionally, CBD was detected in almost 60% of these products when that had not been stated on the label. So CBD was found in close to 60% of the products when that had not been adequately stated. So this is an example where they're scientifically analyzing the products and they're refuting the label claims. They're showing, look, this industry is unregulated. Here's the scientific information. They 2 years later in JAMA, another study was published where they now, instead of looking at THC, they looked at CBD. So they're looking at artisanal products, supplementary products. They found 31%, only 31%, had the correct labeling information for the quantity of CBD. So to explain this a little bit further, this includes products where it may say there's 5% CBD, there actually might be 35% CBD. Products where it says there's 15% CBD, there may be no CBD. So the inaccuracy claims both over and under report. What's even more concerning is THC was found in 21% of those products, and THC had either not been labeled on the label or had been underreported, where they said it might have like 1% THC and there could be 11% THC. I really, really think this data is important because it's just so clear. The American Epilepsy Society in 2019 released a policy statement on the use of CBD, and it clearly states they recommend avoid purchasing and using artisanal CBD products and supplements. And they say these products and supplements are produced and sold with little or no regulatory control. Now, this is really easy to understand, but the problem is a lot of people aren't listening to the American Epilepsy Society, because when we have celebrities like Gronk endorsing CBD and saying it's a life-changing drug, who do you think the public is going to agree with? Gronk or the American Epilepsy Society? Okay. I'm going to introduce now the term medical marijuana. And there is great confusion surrounding this term. It is an extremely ambiguous term that includes plant-based marijuana, the dab marijuana that's derived from the hash oil. It includes CBD and other cannabinoids, and it also includes edible products. So basically, this term is not a clinical term. It's a layperson's term. And this term, the way I see it, is the individual can apply this term to any product under the sun in any way that they want to. There's no standardization of ingredients. And there's great disparity from one source to another source because they are completely different products. When people refer to getting medical marijuana, they may be talking about the CBD oil that they're actually vaping. They may be talking about the joint that they're smoking. They may be talking about one of those fancy products that I showed. Or they may be talking about an edible product like a candy or something that they're consuming, okay? Medical marijuana has not been prepared to pharmaceutical grade quality. It's basically used for any symptom. There's no specific indication for medical marijuana, no specific medical indications. And it's very difficult to do research in this area for a number of reasons. One is marijuana is still federally classified as a class 1 substance. So that is a big roadblock to doing research. And another impediment to research is the variety and the lack of uniformity in the product itself. So over here, I show this to make a clear distinction between actual cannabinoids and medical marijuana. So we started out by introducing the term cannabinoids and defining them as specific molecules or chemical compounds native to the marijuana plant or endogenous to ourselves, right? Cannabinoids, since they are molecules, they are able to be prepared to pharmaceutical grade. This is one entity. Medical marijuana encompasses every single plant species in the cannabis family, along with the altered hash oil. Cannabinoids are actually regulated by the FDA. And I'm going to touch on that in the next few slides. Medical marijuana has been decided by popular vote in different states what the consensus will be. Cannabinoids are delivered through inhalation or they're taken orally. Medical marijuana is used in any manner. It can be smoked, it can be eaten, it can be orally taken. Cannabinoids do follow standard prescribing procedures. Medical marijuana is not prescribed. Everyone should understand this. It is, I'm going to say, loosely recommended by a clinician, because it doesn't even have to be a physician who's recommending it. For cannabinoids, there is solid scientific data, and medical marijuana, it's really nebulous at this time. So when I mention pharmaceutical grade product, I am going to define the pharmaceutical grade specifically as a product that's produced via a very standardized protocol that ultimately contains a regular measured amount of an active ingredient. And this is done in a very specific and consistent and predictable fashion. So it's very clear exactly what is in the product. The FDA has given the approval for 3 cannabinoid preparations: Marinol and Sesabet, which I think that you will already be familiar with. And I'm not going to spend a lot of time on this slide, but I'm just introducing this slide to show you that these are cannabinoid-derived products. Synthetic THC in Marinol is the #1 ingredient, and sesamet, which is nabilone, is a cannabinoid that is very similar to THC, but technically it is slightly different. And there's a third cannabinoid product that has received FDA approval, and that is Epidiolex. Okay. Epidiolex contains CBD as its #1 active ingredient, and it has been given the FDA approval to treat refractory epilepsy in children with these horrible epileptic conditions, Dravet syndrome and Lennox-Gastaut syndrome. So these are childhood epilepsy syndromes where the kids have dozens to hundreds of seizures a day. They can have drop seizures where they completely fall to the floor, severe tonic-clonic seizures that can go into status epilepticus. Often they are on what I call salvage therapy combinations with 4 or 5 anti-epileptic medications, and their seizures are still not controlled. They're really devastating conditions. So this approval is, it is an indication that CBD clearly has anti-epileptic properties. That's not disputed. In the studies that were done, they also looked at adults with refractory epilepsy, and the anti-epileptic benefit was much, much more pronounced in young children than in older people. So that's one thing that stands out about the anti-epileptic properties of CBD. It's scientifically been proven to be much more pronounced in young people. The anti-epileptic medicines in America all carry a black box warning on increased suicidality. This medication so far does not have that black box warning, but in the literature it is mentioned that this is something that needs to be monitored and it should be taken into consideration. Every other anti-epileptic medication has a black box warning on increased suicidality. This one doesn't. This is the first one that is based on a cannabinoid, so they're looking at that now. When people tell you that they're getting CBD, they're not getting it from here, right? A very, very, very small percentage of young children will be getting Epidiolex, and that's probably going to be started and prescribed by a pediatric epileptologist. I hope it is. So when people tell you they're getting CBD, they're getting it from those other sources, all right, that I mentioned. The marijuana plant or supplements. I'm going to spend a few minutes now talking about brain development and the effects of marijuana on the developing teenage brain. So here we have a schema of some functional images of the brain at various stages of development. This is not fully complete. The brain begins to develop before 5 years old, and it continues to develop until we are about 28 years old. The lighter colors here indicate immature brain regions, and the darker colors signify more mature brain tissue. So we know that brain maturation starts in a posterior region and proceeds anteriorly, and the frontal area is the last part of the brain to mature. We know that the frontal lobe is the center for decision-making, for impulsivity, for judgment, for insight, for executive functioning. So what I'm saying here is that it's not a surprise that teenagers have deficits in this area because that's the last area of the brain to develop. So in a sense, they are developmentally staged to not be able to make good decisions, to not be able to have good mood control, executive functioning. Here we have a cross-section of the brain, and it shows what in addiction medicine we refer to as the reward pathway. Here in the center of the slide is what's called the nucleus accumbens, right? And this is a center of highly concentrated dopaminergic neurons. All substances of abuse activate that center. I say they wake up that center. Marijuana, alcohol, nicotine, heroin, cocaine, they all activate that center and release dopamine. And dopamine, of course, is our pleasure molecule, so that's where people start to feel the instant pleasure after using a substance of abuse. What happens next is as the dopamine is released, the dopamine travels through circuits that are directly connected to the prefrontal cortex, and it ultimately will further impair the circuitry that's here that's involved in decision making, in mood control, and in insight and executive functioning. So if someone already is neurologically, not primed to make the best decisions, through activation of the reward pathway, the release of dopamine, ultimately it's going to impair the thinking in this area even further. This is another cross-section of the brain, and all of these tiny pink dots are all THC receptors. So the message of this slide is to show you that while it also works in the reward center, the nucleus accumbens, THC has like wide-reaching effects all over the brain. I do point out it does not have receptors in the brainstem. And this is why we don't see respiratory depression with THC overdoses like we do with opioids and some other substances. This slide is extending that point a little bit further, and it's just breaking down those receptors, the THC receptors, into more specific areas where the actual function is labeled, right? So you can see THC and understand why it affects coordination because it's working on the cerebellum. How does it affect vision? Well, it's working on the occipital cortex. It's affecting the motor cortex. It's working on the amygdala. I mentioned before that THC is fat bound and that it binds to the myelin sheaths. This slide expands that a little bit more. It's showing the corpus callosum, which is the most highly concentrated area of the brain for actual white matter. It's the most densely composed white matter tract in the brain, and it connects the two hemispheres. So it's needed for the one side of the brain to communicate with the other side of the brain. On the right is a person who has not used marijuana, and you can see the robustness and the thickness of the corpus callosum. On the left is a daily user of THC, someone who began daily use of marijuana before they were 15 years old. And you can see that the corpus callosum has actually started to have some thinning, right? There actually are areas where the THC has either been eroded or where it did not initially deposit, where the myelin did not initially deposit because the THC interrupted that process. We see this interference with myelination in two specific categories of people. We see this with teenage marijuana users, and we also see this in adults with schizophrenia, where there are actually what I call like lacunae in the white matter. So THC and memory. We do know, as I mentioned before, that THC works on the endocannabinol system. And I had said that the endocannabinol system is like the volume control for the brain. Think of it like when you turn the volume down on a radio, you're turning down the brain activity. This also works for memories. THC will actually decrease the activity in the hippocampal area, and it decreases the activity in the hippocampus to below a level that's needed to trigger memory formation. So with enough use of THC, you just impair the ability to make memory. With chronic THC exposure, the neurons in the hippocampal area actually will fade away. And brain imaging shows that regular users of THC actually do have smaller hippocampuses than people who have not used THC regularly. Okay. We're seeing an emerging syndrome more and more frequently, and this is referred to as cannabis hyperemesis syndrome. I'm going to ask the people here in the audience, is anyone familiar with this syndrome? Yeah, have you guys seen people with this? Okay, so this is a spectrum condition, and it is seen in people who have, on average, daily marijuana use. And when I say it's a spectrum condition, it presents in some people as severe, like retractable abdominal pain. In other people, it presents as nausea. And I find and in the literature, it's reported, usually that precedes the actual vomiting. But it most commonly presents with people that are vomiting many, many times a day, 5, 6, 7 times a day. They go to the ER, they have these very big workups. Sometimes they're admitted and no exact cause of their like emesis is found or their gastrointestinal pain, and they are discharged, and then this happens, and they start to have 5, 6, 7 admissions to have this worked up. There are only 2 things that seem to help improve people suffering from this condition. One of them is to stop using marijuana, and the other one is hot showers. People will say that being in a hot shower is the only time of the day that they don't have nausea, that they're not vomiting. I've seen people in the hospital with this syndrome, and when I've gone to see them at the bedside, they've been in the shower. And then I've left and I've come back to see them, and then they're in the shower again. And the nurse is saying they're in the shower. So, that's pathognomonic if they're taking many showers. We don't know why that is. It might have something to do with histamine release. I'm not certain. I was talking to a marijuana researcher about this, and she was explaining to me that they're investigating capsaicin, the cream, and applying it to the abdomen to see if that has some way of giving relief to these people. All right. So we now actually know enough background information to look at the question, what does the evidence actually show for CBD as a treatment in youth, right? That's the question that we're hoping to answer. Here I put a picture up of the evidence pyramid just to remind everyone that the strongest scientific evidence is at the top of the pyramid, and that includes meta-analyses and systematic reviews, right? Underneath the top tier come our RCTs. And then below the randomized controlled trials, even though it's the next step, there's actually a very, very big decrease in the quality of the information. So below RCTs, we have cohort studies, case control studies, animal trials, case reports, opinion papers, letters to the editor. Right. So what does the evidence show? Well, for CBD as an anti-epileptic, there is a ton of information, and it's really, really good, strong information. So we have a lot of information that CBD as an anti-epileptic in children works. Okay? There is a systematic review that looked at 36 studies. And out of those 36 studies, 6 of them were randomized controlled trials. So I don't expect everyone to be able to read every single study on this screen. It's small print. The reason I put all of these studies up here is to show you the magnitude of strong scientific evidence that there is for CBD as an anti-epileptic in youth. Okay. So these studies were done on youth with treatment refractory epilepsy. Like I said, they had been on multiple anti-epileptic medications. And what the studies all did was they added pharmaceutical grade CBD to the current anti-epileptic regimens. So this is as an adjunct. This is add-on therapy. And they found that seizure frequency decreased when CBD was added. The drop seizure rate decreased when CBD was added. Some of the children who had CBD added on to their current regimens became seizure-free. For the families, this was miraculous. None of the children who were given the placebo went on to become seizure-free. And also, it was found that there were significant side effects and drug interactions with CBD. This is important to keep in mind. So I just want to show this slide again, even though you've seen it, to remind you, this is what came out of all of those trials. Epidiolex, the active ingredient is CBD, and this has now the indication to add on treatment for children with these refractory epileptic syndromes. The next area of emerging evidence would be for CBD in the treatment of schizophrenia in adults. There were 3 trials that were done here. The first trial, there was some improvement in the positive symptoms of schizophrenia in adults when CBD was added on to their antipsychotic regimens. So I'm just going to briefly say in schizophrenia, there's 2 sets of symptoms, positive symptoms and negative symptoms. Positive symptoms are the symptoms that other people can see. They include hallucinations, delusions, bizarre behavior, paranoia. Negative symptoms are the withdrawal symptoms, the inability to function, the inability to interact with people, the inability to articulate your thoughts, traditionally positive symptoms are easier to treat. So there was some improvement in positive symptoms with CBD. The trial on the bottom was looking to see if CBD could help improve overall functioning and cognition in patients with schizophrenia. And that trial did not show any difference between the CBD group and the placebo group. And the middle trial, there were some slight improvements. They were significant findings, but slight. And that's when cannabidiol was added to anandamide. Anandamide is an antipsychotic that is approved in Europe, but not America. Again, side effects were seen. The antipsychotic medications themselves have very strong side effects. So in this instance, the CBD side effects in some instances were milder than the antipsychotic side effects, though sedation was an issue. I included here a case presentation. I wanted to involve a clinical case because my understanding is that a lot of families are coming with similar concerns that are presented in this case, asking about using CBD. So I'm going to bring Jenny, who's a 12-year-old girl with asthma and Crohn's disease, right now to the discussion. Jenny was diagnosed with Crohn's disease at 6 years old, and she's had abdominal pain, hematochezia, and elevated inflammatory markers. She was treated with 6 mercaptopurine and an aspirin analog. She continued to have active inflammation and symptoms. At 10 years old, she was hospitalized with pancytopenia and a Crohn's flare-up, and she was transitioned to an anti-TNF agent. In the past 2 years, she's continued to have active intermittent symptoms. Inflammatory markers were elevated, and she's had active Crohn's findings on EGD and colonoscope. She's been hospitalized twice with Crohn's flare-ups. Her past medical history, she has Crohn's disease, asthma, eczema. Socially, she's in 6th grade. She enjoys basketball, soccer, and dance. She lives with her family. So at her last clinic visit, she was tearful. She was talking about how she's having a hard time dealing with her Crohn's symptoms. And she's reporting a 6 out of 10 abdominal pain, and her symptoms are interfering with her functioning. So her father is asking if CBD oil would have a positive impact on her symptoms. So what does the evidence show for CBD in youth for other indications, right? Overall, it really shows nothing. There is an immense lack of strong evidence to use CBD for any reason in youth except for the anti-epileptic treatment refractory conditions. While people are making claims, including all of these conditions and many others, there's really no strong, convincing evidence. There are case studies, anecdotal reports, poster presentations, retrospective chart reviews. There are small case series of under 10 individuals. I will say some of those write-ups have some promising findings that are worth looking into, but at this stage, there is no strong evidence to use it for any other reason. And like I said, there are adverse effects with CBD. Some of the effects that, side effects that were reported in the Epidiolex trials, it can influence appetite. There are GI side effects. It's been found to be hepatotoxic. Certain children had to leave the studies due to liver test elevations. It's recommended when you start Epidiolex, you get LFTs at baseline, and then you monitor every 3 to 4 months with follow-up liver function tests. Some of the other side effects included pneumonia, upper respiratory infections, vomiting. There were, paradoxically, some children who were in the CBD arm that did have worsening of their seizures. And these side effects have been found to be dose dependent based on the trials. It's also important to keep in mind, more participants withdrew from the CBD groups than from the placebo groups. I started out my talk by mentioning that there's an interrelatedness between these different cannabinoids. I included this information. I find it fascinating. There have been a handful of studies that have actually shown that CBD can be metabolized into THC. So there was a study that was published in 2017 in the journal Neuropsychopharmacology, where the researchers subcutaneously injected pharmaceutical grade CBD. This is like really as pure CBD as you can get. They injected this high grade, high quality CBD subcutaneously into rodents. And then hours later, they were able to detect THC in their brain and in their serum. So this is evidence that CBD is converted into THC. There are a handful of other studies that show CBD, when it's introduced to gastric secretions, that it actually breaks down into THC. So while this right now is at the in vitro level, the gastric degradation of, it's something to consider for people that are taking edible CBD products. The CBD in their stomachs can be broken down into THC. So it definitely needs to be further investigated. I think that this is clinically something that we should keep in mind if we're giving this product to children. I mentioned that there are drug interactions with CBD. So CBD works on the cytochrome P450 system. This is a very, very, very small selection of the drugs that interact with CBD. In these instances, CBD will inhibit the P450 degradation of the drugs I put up here. So the metabolites of these drugs are going to be increased. The clearance of those metabolites will be decreased, right? This can lead to side effects due to accumulation of these drugs, higher levels than intended. With some of these drugs, they definitely can have EKG changes if they reach high enough levels, like the TCA amitriptyline. Furthermore, CBD, since it's metabolized by P450, drugs that induce P450 will lead to a lower level of CBD than you initially thought. Carbamazepine and phenytoin are potent inducers of the P450 system. So when those are taken with CBD, the CBD level will be much lower than one would expect. CBD in itself, as I mentioned, also is a strong sedative. So when it's given in conjunction with other sedating medications, there's potentiation, and people can be overly sedated. And I just included up here some drugs that really caution needs to be exercised when CBD is given with benzodiazepines, with gabapentin, with hypnotics, antipsychotics, sleep aids. So I am summarizing here by making note that there are hazards with CBD use. And one of the first things to consider is, how is CBD being consumed? Is it being consumed from a supplement? If it's being taken from a supplement, there are many unknowns, right? We don't know the quantity or the quality of the CBD or THC because the industry is so underregulated. There can be toxic additives and adulterants in those supplements. That's been reported. There's variation from batch to batch of the supplements. Or is the CBD being taken directly from the marijuana plant itself? And in that instance, your people that are taking it are being exposed to the harms of the marijuana plant. It's very important to keep in mind, there have been no long-term studies that examine the consequences of CBD use or other cannabinoids to the long-term developmental indices or cognitive development of children. This is something we know nothing about. The AAP has taken a very strong stance on marijuana use in youth. They have a policy on marijuana. It has 11 key points. I just here summarize 4 of those points. The AAP is opposed strongly to the use of marijuana outside of the FDA regulatory process. They support changing marijuana to a Schedule II drug. This would help make researching marijuana more possible. The AAP supports decriminalizing the marijuana when it has been involved with minors and young adults. They don't support the legalization, but they support decriminalization. And where it is sold, they recommend child-proof packaging. And they also have a statement that they never recommend any adults use marijuana products in front of youth to help with modeling. So I've been asked, since the Epidiolex has been approved and there is no strong evidence for CBD in youth, are there any studies in progress where CBD is being examined for use in youth? This is taken from the clinicaltrials.gov page. And I did a search for CBD and adolescents, and 6 studies came up. One of those studies is for CBD and autism. Another is for CBD and Fragile X. And then 2 of the other studies are for CBD and absence seizures. So there are some studies involved, in the works, but overall, there's no, very large single study that stands out. And this is my last slide. When I first saw this, I thought that it was an artist rendering, but I have since learned that Ben & Jerry's has actually developed a prototype CBD flavor ice cream. And they've released to the media that when CBD is approved by the FDA, they plan to release this flavor. Yeah. So this is what's in store for the future. Thank you, everyone. I'd like to do questions now, or are we going to continue?
Maybe questions at the end.
Okay. I'm going to pass the mic to Dr. Shizer. Thank you, everyone.
Thank you, Bill, for that outstanding summary. I still can't get over the mascara. That's like, oh my goodness. All right, so in the next 45 minutes or so, we're going to talk about one of my favorite topics. Personally, we're going to talk about drug testing for adolescent substance use. So really, I have several objectives for the next few minutes. I want to give you guys a really good sense of indications for drug testing in this area. And really, there are two. We're going to talk about using drug testing for diagnostic purposes, trying to figure out what's going on with this adolescent. And then I'd also like to talk a little at the end about using it for therapeutic monitoring, kind of a different indication, which is weekly drug testing for patients that you know are using substances and you're trying to use it as a therapeutic strategy. We're going to talk about proper urine collection procedures. It really matters how you get the sample. And then we're going to talk about interpreting drug test results. And I want to steer you away from these two large pitfalls, which are false negative results and false positive results. And then we'll also talk about, if you're sitting on a positive drug test result, how you share it optimally with patients and ideally their parents. So we know there are a number of biological matrices that can be tested for various substances. I'm not going to say a lot about these. Breathalyzers. I think we're going to see more use of saliva testing in the future. Blood, kind of in an emergency department setting. I don't know a lot about sweat testing. Hair is an interesting story. You can detect heavy use. There's a much longer window for hair testing, on the order of 3 months. You can't detect use in the last 7 to 10 days. It has to do with how the hair grows. And what's interesting about hair is it matters. I mean, my hair would be ideal. The darker hair picks up substances better, but you can also chemically alter your hair and interfere with this test. So just a little bit of background. Really, today we're going to be talking about urine drug testing. That's what we do in ASAP. Remember, we call ourselves ASAP. And there are a lot of reasons why that's our go-to. We know that it's well-studied, standardized, relatively non-invasive. I think the comparison there would be compared to blood testing. And we know that concentrations of either the parent drug and or the metabolite are relatively high in urine, making them fairly easy to detect. And a lot of what we're talking about today is going to be that critical window of detection following use. And so we know for urine, I'm going to go over this in more detail, but think about on the order of 2 to 3 days after intoxication, you can find evidence of the drug. So let's zero in on this topic of indications. We know that if there's a patient where you're suspecting substance use or a substance use disorder, this can be a useful adjunct. And I always think about how we look at laboratory testing in general. It's not a substitute for the heavy lifting. The heavy lifting is always going to be the history and the collateral history and the physical. So it's not going to do all your work for you, but it certainly can be an adjunct. And then at the end, I'm going to talk about more for ongoing monitoring for patients. Oh, okay. So that's the camera. All right, thank you. Looking right at me. All right, so some of this, repetition is important. We're going to go over some points that we might have covered in earlier sessions. When you're getting a history and you're thinking about substance use in a patient, in ASAP, we always use the term red flags. Like, what are the red flags? And there are some that kind of crop up again and again. Change in academic performance, that's a big one. You have a student who used to be an A student who's now a C student, and it's not really clear why the shift. Similarly, here's a student who's now skipping classes, didn't used to. Bill gave us a wonderful description of brain development and brain chemistry and why adolescents are moody. This is more of an exaggeration in kind of the moodiness that we would expect for adolescents. Loss of interest in previous activities. You've got your athlete who used to play a sport, now really isn't that into it. Changes in friends. You're often not going to get this history from the adolescent itself, but parents are really good reporters that suddenly there's this new cast of characters in their child's life. Since we're talking about drug testing, also in your history, you want to make sure you know what prescription drugs the patient is taking, and I want to also include any over-the-counter medication that they're taking. So I think I mentioned this in an earlier talk. Most of the adolescents with substance use are going to have normal physical exams, but there are certain clues that if they're present, you wouldn't want to overlook. Weight loss would be a biggie. That's often what we see with particularly opioid use or stimulant use. It can be dramatic. I'll tell you, I think maybe a handful of times I've seen decreased attention to personal hygiene, so you don't want to wait for that as a finding of significance. Insufflating, I love that word. That's the medical word for snorting. If a patient is insufflating or snorting something, then you might see changes. We always look in the nose in our ASAP physical, and you certainly wouldn't want to miss track marks. All right, so now we're zooming in on this category of clinical indication, which is there's something or multiple things in the history and or the physical, and I'm including the history from the parents, that's pointing you towards drug use, but the adolescent is denying. So the next part of the talk is organized around a series of short vignettes. Each are meant to kind of point me in the direction of an important point. So case number 1, where there's smoke, there's fire. So you're following Billy in your practice. He's 15 years old. If someone does not meet DSM-5 criteria for a substance use disorder, we like the label problem use. So it's not an official term, but it captures these kiddos that don't meet criteria. We've looked at those criteria, but there's something going on. So Billy has done well under your auspices. He hasn't used marijuana in the past 3 months. And then you get a panicked phone call from his mom. He went to a school dance. He came home. His eyes are red. He smells like marijuana. Remember, with dab pens, you won't get that olfactory clue. And so mom is really worried, and she asks you to drug test Billy. So I want you to kind of think about, you're sitting in the room with Billy and his mom, how you would approach this. So I like this slide. This is pointing us towards left column, more useful indications for me to order a drug test. Column on the right, there are other things I can do, but not necessarily a drug test. Generally, if there are specific symptoms of intoxication noted. So I like the example of Billy. His eyes are red. Parents might report alcohol on the breath. For the folks with me in the room, what is nodding off? What does that make you think of? Thank you. That's like sort of number 1. Although I would also add Xanax, benzodiazepines can have that effect as well. Generally, you're going to get more bang for your buck with drug testing if you know what substance you're concerned about. So again, Billy is a good example in that respect. And the time frame is critical. You want to generally be thinking about drug testing if you're hearing a story about potential use in that key 72-hour time frame. So column on the right, less useful indications. Really, the operative word is things are more vague. So a parent might come to you, there's a history of substance use disorders, parent is losing sleep over their child. Obviously, there's a conversation that needs to be had about that, but you wouldn't necessarily say, all right, and let's order a drug test. I still remember being a resident, you never wanted to be accused of doing a fishing expedition. That was like a hand slap. And so again, in general, if a parent comes to you with vague concerns, those need to be addressed, but you wouldn't necessarily say, and let's get a drug test. One of the banes of my existence in this category would be there are certain substances that are just not easily detectable in drug testing, no matter what we do. And it's good to have those in your mind. Inhalants are really the biggie. These are excreted primarily through the lungs. So you don't see any metabolites in the urine. Over the years, we've had a handful of patients with severe inhalant use disorder, and drug testing is of no help at all. The other category that I think is significant is anything that's a new designer drug. Kids are ordering synthetic benzos online from Europe or something like that. I'm probably not going to be able to test for those in a drug test. And again, time frame, which I've mentioned before. All right, let's go back to Billy. He denies marijuana use. He agrees to a drug test. Let's look at the result that you get. So the screen is positive for cannabis. We're going to talk about random urine creatinine and what that means. So that's 150. And then you have a confirmatory test, GCMS, which is positive. All right, so you're all thinking about Billy. Billy denies use. And after kind of going back and forth for a couple of minutes, he says, you know what? I must have been around it, secondhand smoke. So you're thinking, am I buying this? We'll come back to that in a minute. So when you order a drug test, what are you actually getting? If you're ordering it correctly, you're getting a 2-part test. The first part is going to be an immunoassay, which is the inexpensive part of the drug test. This allows you to screen for multiple drugs at the same time. They're very efficient tests. And the point that you really need to understand is these are concentration-based. So the immunoassay will pick up that a substance is present in the urine sample if the drug or the metabolite is present at or greater than a specified concentration. So THC, typical cutoff would be 50. nanograms per ml. So if it's less than that, the test will be negative. If it's higher than that, the screen will be positive. So this has a good sensitivity. You're not going to miss much. But the flip side, as you think about screening tests, is that you will generate a lot of false positives. And that's why it's really important as you're drug testing your patients that you set it up that all of the positive screens will then default automatically to a confirmatory test. This is how you deal with the category of false positives. These are the gold standards. This is the expensive part of the test. So sometimes in the community, I'll see a test that's done that's just a screen, usually to save money, but you're not getting all the information. And you can also get quantitative levels, which we'll talk about for THC, how that can help. So who in the room with me knows about hotboxing? All right, actually quite a few hands. And I just learned that in New York, it's clam baking. So you learn something new every day. This is the phenomenon where adolescents would be in a small, closed space. Unfortunately, that's often a car, which is the last place you'd want them to be. Some of them would be, let's say, smoking the marijuana product. Others are not. So they can say, I wasn't smoking. But it's a small enough space with enough smoke that everyone is getting some effect. And so that is what Billy was doing in this case. And generally, if we see THC in a urine, we say that's use. We don't like this excuse that it was a secondhand exposure, because if it was in your urine, then it was in your brain, as Bill talked about. All right, moving on to case number 2, big gulp. Now you're seeing Alex in your practice. He's a 16-year-old boy, got in a lot of trouble at school for marijuana, and so he was expelled. So he comes to you with his parents to figure out next steps. He is completely denying marijuana use. He agrees to a drug test, and then this is what we get for Alex. So his drug screen was negative. That's interesting. Urine creatinine was 6. Your wheels should be turning. What do you do next? All right, so the next topic that I want to take on would be, we're talking about interpreting drug test results, and there's a very big category of what I would call false negative drug test results. And I define this broadly to include the patient is using substances, and for whatever reason, you've gotten a negative test result. So as we think about this patient, I think it was Alex, probably the number one category would be intentional dilution of a urine sample. And then the plot thickens. You can have adulteration of a urine sample, which means something was added to the urine, which will interfere with the screening immunoassay. Kind of going to the spectrum of, I'd say, chutzpah, the chutzpah spectrum. So you can substitute a different urine sample. You think you're testing Joey's urine, but you're actually testing someone else's. Then the last 2 categories on this slide are a little more nuanced. One example of a false negative test would be the adolescent is using substances, but you're not going to capture it with your panel. Either it's not testable or your panel doesn't include it. And then the last category would be, yes, they've used a substance, but you missed it in your window of detection. It was outside that window of detection. All right, so who's familiar with the idea of dilute drug tests? Okay, I think that's pretty much out there. Thank you. So we know that this is one of the most common methods to attempt to, I use the phrase beat a drug test, and that's what you'll see online. Generally, this can be done in vivo or in vitro. In vivo would mean that the patient consumes a large quantity of fluid deliberately prior to submitting a urine sample. Remember, in the immunoassay, it's concentration-based. So if you have a very dilute sample, you can theoretically drive that concentration below the level of detection, and you're not going to get a confirmatory test in any setup if your screen was negative. In vitro dilution, we had a patient who did this recently, where you're adding water to the urine sample is collected and then you add water to it. So the teaching point here is that you must have some marker of concentration when you get a urine sample. Random urine creatinine, we all have muscle breakdowns, so we all have some level of creatinine in a random urine sample. If the number is greater than 50, I'm happy, end of story. This slide shows you different numbers. Generally, if you're in the 25 to 50 range, I call that a gray zone. It could be that the patient was trying to dilute a sample, but it could also be just a very well-hydrated individual. Maybe they were asked for sample right after. I see people with these large Dunkin' Donuts drinks, so it could be something like that. So you would give them the benefit of the doubt, and then you would ask them to get a repeat sample with specific instructions to limit their fluid intake. I think we like to say less than 8 ounces in the 2 hours prior to collection. As that number gets lower, I get more and more concerned. Generally, if you're seeing a creatinine in the 5 to 25 range, it's pretty hard to do that without trying. So I'm going to consider that a positive test, even if the test is otherwise negative. Every now and then, to make life interesting, we'll get a creatinine less than 2, which of course is kind of flagrantly positive. That's just not physiologic. So I think we're running a little late. I won't talk to you in detail. So quick and dirty, you drink a lot of fluid. You can use a diuretic. Creatine, if you're taking it, like from a health food store, this would be for the diehards. It can artificially boost the creatinine that I'm going to see in their urine, so I might miss that this was dilute. And apparently vitamin B can increase urine pigment. Who knew, right? One of the things I like pointing out is there are people, grown-ups, as it were. Yes. Probably not. That's a really good point. That would probably capture it. Nice question. So there are adults in the workplace who are trying to, quote, beat drug tests as well. So there's a lot of information, unfortunately, about this online. There's kind of a lot of creativity out there. So adulterated tests, what I've said before is that you added something to the sample that's going to interfere. This is always on the level of the screening immunoassay. And I think the point of this slide is these are common chemicals. These are not obscure chemicals. And sometimes they might be right in the bathroom cabinet where the adolescent is giving a sample. All right, lots on the internet. I'm going to move on. 10-pack of powdered urine. This is what your patients can purchase. And I think what you'll see is as the stakes are higher, kind of the appeal of these products increases. So do not despair. There are ways around this, and it really boils down to proper urine collection procedures. The gold standard is always going to be direct observation. We have a program that I'm going to tell you about where parents collect samples at home. Whenever possible, we always encourage a parent to literally be in the bathroom. They change their kids' diapers when the sample is collected. That's going to be your gold standard, or right outside the room. There are some scenarios when that's not an option, and then we like to use what is literally called the Department of Transportation protocol. This is used for federal workplace testing. So think about what I'm saying and how that would help in collection. So the patient shows up at the lab, they have to show their ID, they are who they say they are, they go into the testing laboratory with empty pockets. In the facility, in the laboratory, so where they're giving the sample, you can see where I'm going with this. No running water. The toilet water is dyed blue. And this is very important, and you can easily import this. You check the temperature immediately. And this could be a parent giving an adult, taking the sample and just saying, this feels warm. That's good. We have cups that actually have a little temperature strip, because urine, if you've just voided, should be body temperature. All right, so the internet, the urinator, people know this. People know that temperature matters. So you can purchase a one-of-a-kind, state-of-the-art electronic urine testing device that will maintain testing temperature for a minimum of 4 hours. There's an anatomically correct version that's called the Wizinator that comes in different skin tones. I really couldn't make this stuff up. So I'm just gonna, in the interest of time, woman pleads guilty in fake penis case. Hopefully you'll be able to read this on the slides. It'll probably be tiny, but this is someone who had one of those devices. Again, I couldn't make this up. All right, so moving on, we're thinking about false negative tests. This category I think is harder. This is that you're getting an adequate urine sample, but the substance just was not detected by the panel. So this is my teaching point. Know what your panel encompasses. If you've ordered drug tests, or you will, see what substances are covered. There's often the potential of adding additional substances to it. We've been doing a lot of testing for nicotine and cotinine, given the vaping crisis. You can add cotinine, which is a metabolite of nicotine. A lot of panels will not include alcohol. For adolescents, I think you really want to add metabolites of ethanol. So know what you can test for, know what's on your panel, and then there's always going to be this category for the kids who are super motivated in a bad way. You might potentially push them towards other substance use, which is really one of the big disadvantages of drug testing for a specific phenotype of adolescence. Window of detection, I've alluded to this several times. Generally, if your brain can remember one thing, remember 48 to 72 hours, because that's the most common window for various substances. THC is an interesting exception. I'm going to talk about that separately. It depends on whether you are a sporadic or a heavy user. I also want to highlight that cocaine is very quickly in and out of the urine. So that tends to be by 48 hours, it is long gone. If there's someone I'm worried about cocaine use, that's someone I'm going to test twice a week, not once a week, because otherwise you can miss it. All right, case number 3, how did that get in there? Now we're thinking about Justine, who was caught with marijuana. She's admitting use in contrast to our last patient. The school has asked you to get involved for medical clearance. She's agreeing to the drug test. She's not giving you a hard time, and she says it will be positive for marijuana. So you get the screen back. It's positive for cannabis as expected, cocaine as well. Random urine creatinine of 62. Do we like that number? Perfect. It's over 50. We're good. So you get a confirmatory test, which tells you the same thing. You're getting cannabis and cocaine, and then we'll talk about quantitative levels in a couple of minutes. All right, so Justine, so a little bit of a twist. So whenever you get a drug test result, you have the patient come back, you meet with them privately to go over the result. In Justine's case, she's already given you that she's using marijuana, but she absolutely denies intentional cocaine use. Again, there's a little bit of back and forth. And then she said, my weed must have been laced, must have been in my weed. This is unsatisfying, and that's the point of this little vignette. It's interesting, if you think about the chemistry of cocaine, it comes in a powdered form, which I know is just much more common in Massachusetts, and that has a melting point that shouldn't allow it to be smoked. That's the whole point of crack cocaine, which requires a chemical manipulation to lower the melting point, freebasing. I used to know all the chemistry of this, but it doesn't really make sense when patients say that the cocaine was laced into their weed. So some of these drug test results are going to be unsatisfying. Did she actually use cocaine? Was that the story? So that's the point of that vignette. You don't always get full closure. All right, moving on to case number 4. Angela is a 17-year-old girl, non-specific signs of drug use. Remember my discussion of all those red flags. So mom looked through her things, found a bag of marijuana in her coat, and then brings her to your office to have a conversation about that. So Angela agrees to a drug test, and this is the result that you get. So the screen is positive for cannabis and opiates. We like the random urine creatinine, and then the confirmatory test gives you the same information, cannabis and opiates. So we're thinking about Angela. All right, so this is when I go over THC excretion. So you meet with her privately. She does remember, okay, she did smoke marijuana one time 3 weeks ago, absolutely denies use of anything in the opiate category, but she remembers after some prodding that she took an over-the-counter cough syrup. I'm not talking about codeine. That would be too easy the day before the test. So we're scratching our head thinking about what she's telling us. So in my practice, I see that there's a lot of confusion about seeing THC in a urine drug test and what the time frame is. And I think parents often come confused, and I like to kind of debunk the confusion. So really, you have to think about 2 different populations of marijuana users. If someone is a sporadic marijuana user, let's say they're using it once a week, then it really is that 72-hour window that I taught you for most substances, that you're going to see THC in the urine for about 3 days, 3 to 5 days at most, and then they're going to clear. I would say the plot thickens, or it's more complicated for your heavy marijuana users, because as Bill told us, it's stored in fat tissue, those myelin sheaths. And so what this means is that if someone is a heavy user and then they stop, that's where you get the prolonged excretion. So they will have THC in their urine for up to even 6 weeks after they stop. But again, there's a lot of confusion where if a child has a positive drug test, they tell their parent that they used a month ago, and their parent says, okay, that's not okay unless they used very heavily and then stopped. So I like to explain that point. The opiates, opioids, we did have the opioid webinar. I think the point that I want to make here is that as you're looking at your panel, there should be an opiate screen and an oxycodone screen. A test for opiates is really going to point you towards heroin use. You're going to detect morphine and codeine, which is how heroin is metabolized. An opioid screen, so if someone is using Percocet or Vicodin or one of the synthetic opioids, your opiate test will be negative. And I've campaigned for years. It astonishes me that the urine tox screen that's done in the emergency department at Boston Children's Hospital has an opiate test, but not an oxycodone test. So, there are kids sent to the ER to rule out use of various substances, and they're missing potential oxycodone use. This patient kind of was throwing you a smoke screen. Dextromethorphan can give you a false positive screen for another substance, but this was meant to be opiate use in that case. So this segues into a discussion of false positive results. Remember, we talked about false negative results. And there are two categories of false positive results. The first category would be you get a positive test on your screen, but then you do a confirmatory test, as I'm encouraging you to do, and then the confirmatory test is negative. So there are a number of substances that cross-react. Remember, this is an antibody-based test, and so the screen is a little confused, flags it as positive, but then your confirmatory test says, nope, not present. I don't see a lot of these. The one that I do see that's good to know is that a lot of patients are on sertraline. That will give you a false positive screen for benzodiazepines, but if you're doing the confirmatory test, that will come back negative. And examples like if a patient is taking a fluoroquinolone, that will give you a positive screen for opiates. Really, the take home of this slide is don't just order a screening test. Don't try to save money because you might be in one of these potential quagmire situations. All right, who's a Seinfeld fan? Who can guess where I'm going with this? Am I dating myself? Right, Elaine, exactly. Yeah, that was good times. So the next category of false positive testing is maybe a little more subtle. This is that you get a positive screen and the confirmatory test is positive, but this is a patient who's not using substances. So the best example, and this really happens, is that someone eats an everything bagel or a poppy seed bagel, and then they get a low level of opiates, morphine and codeine, in their urine test. And that's because poppy seeds are derived from opium, and so they actually will test positive. The confirmatory test will echo that, but this is not a patient who's used opioids. So there's always going to be what we say clinical context, clinical correlation. I've always heard about these fancy teas from South America that can contain, I don't know if they contain trace amounts of cocaine, so you'd have to worry about that. Really another big category, and remember I made a plea for knowing what medication your patient is taking. If they're taking Adderall or Vyvanse, of course they are going to test positive for amphetamines, but that doesn't mean illicit use. That could be licit, which is a fun word to say. All right, so some of you might be thinking, well, that's great. All of these patients are saying yes to a drug test. What about the patient that says no? So that's case number 5. All right, Adam is 16 years old. The school is horribly worried about Adam. He's one of those kids with all the red flags. So the parents are worried about him as well. So he comes in to meet with you. So you meet with Adam privately, you do the best you can for substance use history. He does acknowledge occasional marijuana use and occasional alcohol use. He gives you nothing else, and he's just annoyed. He's annoyed with you, with his parents, with the school. That's how he presents. So you ask Adam to wait in the waiting room, then you meet with his parents for what we call a collateral history, and then you're really worried as well, based on what you're hearing. So after that, you meet with Adam and you ask him to give a drug test, and this patient says no, he refuses. So does the story end there? The answer is it does not. So Adam's parents do something very logical, which is they say to Adam, we're really worried about you. We're worried that you're using something, and so we don't feel comfortable with you driving the car. If you want the car back, then you have to agree to do weekly drug testing, and then we'll negotiate whether you can drive again. So Adam at first says, okay, fine, I don't need to drive. And then he gets a little desperate, and so he agrees to do weekly drug testing after that. Reluctantly, but he agrees. So the first test is a low level of marijuana. He negotiates with his parents and they let him keep driving. And then the second test is positive for marijuana and morphine. All right, so I'll come back to Adam in a minute. This is a really important point. The explicit policy of the American Academy of Pediatrics is that we are not supposed to order a drug test without the patient's consent or knowledge. Every now and then in ASAP, I hear about parent will tell me a story that the child was tested, the pediatrician did a drug test without telling the child, and that's really a no-no. But on the other hand, if the adolescent refuses, the story doesn't end there. And there are examples, just like what Adam's parents did, where you say, okay, well, you're not going to do this. We're still worried about you. So we have a plan B that we're going to use. I think we sent this to you this week. There's a really nice clinical report Dr. Levy, who's our medical director, published in 2014 with a lot of good information about clinical drug testing. And this is an excerpt. Many national organizations, including the AAP, have consistently cautioned against involuntary drug testing in adolescents. I love this sentence. Adolescents should be engaged in their own care. Anything that we're trying to do, including substance use treatment, you've got to kind of work with them to be a willing participant. Drug testing of a competent adolescent without his or her consent is at best impractical, and without his or her knowledge, wow, unethical and illegal. So strong language, that's really not an option for us. So the story, the take home with Adam, and the reason that I like weekly drug testing is because of this phenomenon of windows of detection. You know, I think what was going on with Adam was he was motivated, he wanted to get the car back, so he was able to abstain for a few days, and that's why the first test was negative. But eventually, if someone has a substance use disorder, they're going to keep using the substance, and even if you might be out of line for a couple of samples with this window of detection phenomenon, you're going to catch it, and that's really the take home for that case. All right, so we have the positive test result. We ask the adolescent to come in. Usually these are in-person conversations. We're very reluctant to give results over the phone in general. You always want to meet with the adolescent privately. You've heard me say that before for any discussion really about substance use. And you want to get a good history of any medications and anything that might clear the picture. We've had patients with very concerning drug tests, and then it turns out they had a medical procedure and they were given, fentanyl and a benzodiazepine. So you want to make sure you know what happened around the time of the drug test. One of the techniques that I really like, I'm sitting in the room with an adolescent with the drug test result. I don't say, this is your drug test result. It's more of a give and take. And I'll be deliberately vague. I'll say, we have a drug test result. Tell me what you've been using. And then I'll ask that in many different ways. I'll kind of run the list of substances. And the beauty of this technique is, especially for someone using more than one substance, they don't know what you have. So you might get more information than you had even with the drug test result. So as you know, we're a family-based program. I think most of the time, if you're getting a drug test result, there's going to be a parent involved. So the second part of the visit would be sharing this result after you've talked to the adolescent with the parent. And this is when we kind of switch gears and we're the adolescent's advocate. So ideally in this conversation, after you discuss the result, there's some acknowledgement that he or she will continue treatment. So it could be continuing weekly drug testing, meeting with a behavioral health clinician, coming back to see you. So something that you can put a positive spin on. You're going to keep the report brief. These are tense conversations for sure. But for example, you would say to the parents, less is more. Joe had a dilute drug test and told me he used marijuana and took some pills last week. You want to kind of keep the parents focused on the future and the positive. I mean, these can become very explosive conversations, but it's your job to try to keep everyone focused on where do we go from here. All right, so I'd like to now change the focus. We talked about using drug testing more in a diagnostic capacity. This is more in a therapeutic capacity, and this is what we do a lot in ASAP, and I would invite you to do it in your practices as well. So if we have a patient with established substance use, maybe we've given them a diagnosis of a substance use disorder, we would suggest weekly random drug testing for monitoring. If you're on a diet, you're going to step on the scale once a week. It's really more that sort of thing. Sometimes patients will be willing to do a quit attempt. They'll accept what we call an abstinence challenge. And in that context, it can be very useful to say, okay, let's follow weekly drug testing. Who's familiar with contingency management with that phrase? Is that fairly mainstream? there's a lot in addiction medicine about contingency management, which is a fancy way of saying that there will be predictable positive consequences or rewards for negative testing or improved testing, and then negative consequences for ongoing use. So in the literature, particularly with adults, which is really where more of the literature is, this works. Drug testing with contingency management. As we already talked about, the patient may initially refuse. You may have to warm them up a little and find kind of an incentive for them to agree to do this. So I'm going to tell you about our program. And again, I hope your wheels are turning that, I can do this too. Generally, we do 3 months of weekly testing. Probably everyone understands why it should be random. It wouldn't be very good drug testing if the adolescent was choosing the day, because then they could do a drug test, use, and then choose the next drug test. Historically, we've had collection done in the lab, but we're not now doing a lot more home collection, which has advantages. And we always encourage parents, ideally, if a same-sex parent can be in the bathroom at the same time, that's going to get around some of the problems. We also always invite them to get the first morning sample. Remember, concentration is a big deal. And generally, first morning urine is going to be the most concentrated, so we don't have to worry about borderline low creatinines. All right, so according to our protocol, negative drug tests are great. No one has any extra work. If there's a positive or what we call an unexpected drug test result, then typically the parent would get a call. This is how we set it up, asking them to bring their child in for a visit. This is a medical visit so that we can discuss the result in person. The exception to this protocol would be if there is a acute safety issue. And we've talked from the beginning about safety and how we handle that. So if there's something in the drug test that is so concerning that we don't want the parent to wait 2 weeks until they come in person, we will give that information over the phone, and we'll often say, you might choose not to discuss this with your child, but we just wanted you to know there are opiates or there is Xanax or cocaine in the urine. That generally would warrant information over the phone. So something that we've been doing, and I want to kind of give you a little primer on how to do this, is a lot of our patients are patients with cannabis use disorder. They are not, remember the stages of change, maybe they're somewhere between pre-contemplative to contemplative. They're telling you that they're going to keep using marijuana, so why would you want a drug test? And the answer is that we get these levels. So for THC specifically, you get a number that's meaningful and is a general reflection of how much they're using. So if they're willing to have a seat at the table, you can drug test them weekly and you can see if you can get their levels to come down. I think it's a little bit of harm reduction because generally we are abstinence-based. That's our goal. But sometimes you have to meet patients where they're at. So just the mechanics of this, we're going to look at some drug test results, but you get a raw THC value in a drug test, and then we always get a random urine creatinine. So if you divide the THC by the random urine creatinine, that gives you a number that you can compare from test to test because you've essentially kind of corrected for differences in concentration. This is not in the literature. This is my own gestalt, but I feel like it's very helpful. As you get to know these levels, in my mind, they usually fall into one of 3 categories. Low levels would be less than 100. Then think about that middle of the bell-shaped curve, which is really the widest part. Kids who are getting THC levels in the 100 to 1,000 range. And then Bill was talking about dabbing and dab pens and that sort of thing. These are the kids who are going to get the highest levels. Kids who are using high potency marijuana, you're going to see 4 digits. So if I have a kid that I'm monitoring, if they're starting out with 2,000 level, something like that, then I can say, well, let's see if we can get that level down. And that's a start because you're starting them along that path towards behavior change. All right, so this is an actual patient that I saw in clinic. He was, I think, a 17-year-old with a moderate cannabis use disorder, came in for his evaluation, told his parents after the family meeting that he was willing to stop marijuana use, and he agreed to drug testing. So you could see the test on, I'm just kind of going down the list. So November 21st, we always call the first test a baseline. So unless there's something really alarming, we just sort of let that one go. So the THC level was in the 400 range. The next test was lower. So this could have been prolonged excretion with the number going down. And then if you're following me, I don't have a pointer. December 5th, it went up. Okay, so that's no use. So this is not excretion, this is he's using. At that point, the patient came in for a visit and the parents were activated by this visit and they said, you know what, you're not going to drive. I mean, this really happens, hence the picture of the car keys. You're not going to be able to drive until we can tell that you're not using. And he had told them at first that he wasn't. So I think they felt betrayed by that. So then look at the numbers. So now we actually are seeing the numbers going down. I just saw him in clinic on January 21st. This is definitely consistent with prolonged excretion. The money is really going to be in the next couple of tests. Sometimes you can have plateauing at the lowest levels, so I'm not bothered that it was 26 and then 25, but we'll see. And he is just now starting to get the car back. So parents are pretty psyched, and we'll see how he does. Yes. Yes. Thank you. Thank you so much. So I made a brief reference to that before. It deserves another mention, so thank you. So we have a lot of kids who come to us. Really, the two concerns we're seeing the most now are marijuana and nicotine with all the vaping that's going on. So if I were here 5 years ago, I wouldn't have shown you cotinine on a slide, but now we've added nicotine to almost everyone's standing order, and then the metabolite for nicotine is cotinine. You could see he's kind of all over the place with his electronic cigarette use. Generally, Quest says a level less than 20 is negative. So some of these levels are higher, and it's in your urine for about 3 to 5 days after use. Well, fantastic question. So if someone has accepted nicotine replacement, then you really don't even want to get a cotinine level because we don't have a way to tell them apart. So thank you. That's a fantastic, both of those are great questions. All right, I wanted to say a word about home drug testing. There are patients who, it's either going to be more expensive or less expensive to home drug test, really depending on what insurance is willing to cover. It is an option for families where insurances won't cover the cost of lab-based testing. If you have this conversation with families, there's something called CLIA wave test. I was looking on Amazon yesterday just to see if I could see it. Generally, those are for professional use. So that's a quality control that you can give your families. Make sure what you're purchasing says CLIA waived. An advantage of home drug testing, for me, they wait 3 to 4 days to get a result. This gives you, it's like a pregnancy test. You get an immediate result. I think the disadvantages of home drug testing are significant. Generally, these are enzyme tests. So remember what I taught you about enzyme testing. You get a screen, but you don't get a confirmatory test. So there is a potential for false negatives. Generally, these kits don't include alcohol and nicotine, although there are some products that will test just for nicotine that I'm seeing more on the market. You're not going to get the quantitative THC levels, so you don't have that opportunity to follow levels, which is something we can offer. And I would say if there's someone you're really worried about who's using a variety of different substances, that one really needs medically supervised drug testing. All right, in the next 5 minutes, I think we'll just make it. Again, we have a lot of patients who are participating in our weekly drug testing program. So I've highlighted some patients, which will show you some interesting drug test results. So a very standard patient, this is a 16-year-old who we're following. Again, mostly we're seeing cannabis and nicotine. That's what we're seeing these days. So he comes in, and he's one of those kids that has told us that he's continuing to use marijuana. So what we're trying to do motivationally is have him cut back on his levels. All right, so I think you guys can see the numbers. So I just want to show you a standard drug test. You can see the cotinine on top. I should have a pointer for this, is 3,000. I will say that with electronic cigarette use, we are seeing incredibly high cotinines. And that just talks about the extent of the exposure that kids are getting with vaping. And then there's the marijuana. You see, this is what I mean by the raw THC, 1776. And then you can see the random urine creatinine. And so I would divide the 1776. I'm not wearing my glasses. I may be a little off. Oops. Okay, sorry about that. By the creatinine, glasses go on, and then that would be a number. So 1778 divided by 192, that number is about 900. So this kid is a significant user, and we're going to see what his next results are. All right, and these are not the actual patient's names. Aiden, I almost said his real name, is a 15-year-old boy from the Cape, has a severe cannabis and nicotine disorder, very significant mental health issues, significant SI. Whenever he comes to see me, I usually have him seen by a social worker for safety assessment, kind of a really worrisome kid. So he got this drug test result, and I want you to look towards the middle of the screen. So yes, he has cotinine, fairly low level of marijuana. Who sees the methamphetamine on the screen? I've been at ASAP for 11 years. I've seen maybe 2 tests for methamphetamine. We know that it's on the West Coast. I think eventually it's going to work its way to our neck of the woods. But that is what it looks like. That's a confirmatory test for methamphetamine. So dad got a phone call, again, this would be that safety issue of we're not going to wait 2 weeks to tell the parents. I met with the patient. It was unsatisfying. He completely denied methamphetamine use. The best I could elicit was he was with a sketchy group of kids. He borrowed their vaping device. Maybe it was laced with methamphetamine. So, this is not like a 1-hour drama on TV where you get nice closure. Sometimes you don't. But then the importance becomes serial monitoring. I haven't seen methamphetamine in another test. So we just keep track of it and shrug our shoulders a little bit. Oh, methamphetamine. Yeah, no. So if you look, so you see amphetamine, so positive means the screen was positive. Amphetamine, 6666, methamphetamine is what you see. So this is really important chemistry. Methamphetamine, crystal meth, we all know it as meth, breaks down into amphetamine, not vice versa. So if someone is taking Vyvanse or Adderall, you'll see amphetamine, but it won't, it's sort of a one-directional pathway. It won't become methamphetamine. All right, 14-year-old, one of our lighter patients comes in with cannabis use. He agreed to regular drug testing. So what do you see on that slide? Because we're running out of time, maybe I'll be a little more directive. So his opiate screen was positive, morphine was 140. Based on something I said earlier, what do you think that is? 14 years old, kind of a light case. Do you think he suddenly started using heroin? What else could it be? Or he went to Brugger's and he had a poppy seed bagel. So that's why I'm showing this slide. That's really, now we take it seriously. Parents get a call. This is a scary drug test result. So we give the parents a call and we'll still bring him in. But if our index of suspicion is almost 0 for new onset heroin use and we get a good story for an everything bagel, that's okay. But then we say no more everything bagels because we're going to get more worried the more we see this. All right, so this is a very standard patient, 18-year-old, severe nicotine and cannabis use disorder. Remember stages of change. He's pretty pre-contemplative. He's not telling you that he's going to stop his marijuana use, but he comes to his appointments and he's engaging in drug testing. He's prescribed amphetamine and sertraline. That's really the point of this little case. So if you look on his slide, so you see the amphetamine. So that's what it looks like when you're prescribed a stimulant, but you don't see methamphetamine. Benzodiazepine, negative confirmed. Remember, sertraline will give you a false positive screen for benzodiazepines. That's why you need the confirmatory test, which was then negative. And then this is one of my heaviest users. Does everyone see? Sometimes the THC is so heavy that my assay says I can only say greater than 5,000. So we have our kind of coterie of patients in that boat. And again, I don't want to make light of it. He does come to his appointments where a patient like this, the incentive would be, well, let's see if we could get a detectable THC level. It's motivational interviewing. Let's just try to see if we can push him along, while in the background, we're working with parents on some sort of a contingency management approach. All right, this is one of our most really scary patients. This is a 23-year-old with a severe opioid and alcohol use disorder. She survived numerous opioid overdoses, the cat with 9 lives type of story. We treated her in our Suboxone program briefly this fall after she had been inpatient for a long time. This is for sure the kind of patient that I lose sleep overnight. So this is what a really scary drug test result looks like. So she's using alcohol. These are your alcohol metabolites, using cocaine. She's taking her Suboxone. It's not doing a lot of good, but you can see buprenorphine in the urine. And then the really chilling aspect of this slide is she has greater than assay fentanyl, the norfentanyl, which is a fentanyl metabolite. And this patient, her opioid of choice is fentanyl. Like, we're not talking about heroin laced with fentanyl. That's what she's using. So she went to a higher level of care shortly after this. This is a patient in our Suboxone program who's doing well. We've known her for several years. She did start using marijuana briefly, so we're talking to her about that. This is a medical mystery. This is ongoing. So she is having trace amounts of fentanyl in her drug tests. We've now had 4 in a row. I'm looking at Bill because we're discussing this weekly. she's completely denying any return to opioid use. Her last use was heroin 5 years ago. And so we're wondering if there's something in her marijuana, and we're actually going to send her marijuana to a national lab to see if they can tell us if it's contaminated with fentanyl, because if it is, we'd like to put that in the literature. So we're trying to figure out if she can bring marijuana to Children's Hospital for a collection. You have to check with all the chiefs whether you can do that. All right, last patient is a 15-year-old girl, again, ASAP light, kind of one of our lighter patients, agreed to drug testing, and what do you see? Yeah, and again, she's kind of doesn't really fit the profile of who we think. So mom got a call right away that she was tampering. We asked mom to be in the room. What was really interesting is we got a few more of these with mom in the room. There was a lot of back and forth because this is not physiologic. And it turns out that this wily teenager was able to add toilet water to her sample while mom was maybe 2 feet away. So you got to use all your faculties when you're treating these patients. It's kind of fun. If you have any questions, thank you, Jonas, for highlighting our consult line, which is now via McPap. And there's my summary slide, but I'd rather take a question.
I have a question about what is the proper language to ensure that we're ordering the confirmatory laboratory test. That's not an automatic thing.
Yes. And I thought about including a slide, but it was kind of dry. I can share with you what the orders are for Quest. Again, it might be a phone call to your laboratory, but usually with Quest, it's a custom panel. Most labs will automatically do a reflex confirmation test, but it might be a phone call saying, I just want to make sure I know what I'm getting. Are you guys doing confirmation? You'll see LCMS, which is liquid chromatography, GCMS. So I can send you Quest standing orders, what that looks like, but also a phone call, just now that you know the language. Was there one other hand? All right, I know we gave you a jam-packed session. My apologies.
One other question is whether there's any gender differences between the tampering drug tests.
Oh, I love that question. You know what? It really travels with what the stakes are. This 15-year-old, her mom was laying down the law, and she had a problem with nicotine. She really wasn't using anything else. She would lose her phone if she had a positive drug test. So 15-year-old, cell phone, that was what was driving it. Bill, I don't know. I can't say that there are gender differences that come to mind. It really, most of the time, it's what the stakes are and how far they're willing to go. And some kids are just defiant. They want to see what they can get away with. All right. Thank you, everyone.
It's just a process thing. I called it